Prima ringrazio Edoardo e Luigi per avermi chiesto di riassumere un intero testo di medicina interna in 15 minuti. Um, First of all, I think that we all appreciate the fact that as heart failure progresses, it goes from a hemodynamic phenomenon to a neurohormonal activation phenomenon, and ultimately it becomes an inflammatory as well as a metabolic disease. And specifically, we can say that the two fundamental issues in heart failure are catabolic activation through catecholamines and glucocorticoids. Don't forget that cortisol occupies all the mineralocorticoid receptors in the heart, but also anabolic deficiencies related to deficiency in sex hormones, insulin resistance, and growth hormone resistance, which, by the way, appears to be improved by ACE inhibitors. I will discuss first insulin resistance because it's probably the most important endocrinological problem in chronic heart failure. You know all the factors in heart failure that do lead to insulin resistance, but I would like to point out that once insulin resistance is established through hyperglycemia, hyperinsulinemia, impaired energy efficiency, and lipotoxicity, this in itself leads to systolic and diastolic dysfunction, fibrosis, apoptosis, and hypertrophy. Don't get scared by this complex diagram. What I would like to point out especially is the IRS, which is the insulin receptor substrate. And the most important thing that you need to remember is that there is an insulin resistance at the level of the cardiomyocytes that is independent from systemic insulin resistance. However, systemic insulin resistance does aggravate myocardial insulin resistance. And although it appears to be very complicated, the things to remember is that all the neurohormonal defects that occur in heart failure cause a change in the insulin receptor substrate. And specifically, they cause the phosphorylation of the serine end of the substrate. And when this happens, mTOR and serine kinase 6 become activated, and this leads to oxidative stress within the cell, but also causes a lot of issues within the mitochondrial, decreasing their ability to oxidate glucose and increasing free fatty acid oxidation, which in turn augments oxidative stress and potentiates further phosphorylation of the serine end of the insulin receptor substrate. And with all these events, you end up with an impaired calcium uptake in the sarcoplasmic reticulum, which causes diastolic dysfunction and contractile dysfunction. You get metabolic inflexibility, which leads to decreased cardiac efficiency, and the dysfunction in the mitochondrial and endoplasmic reticulum leads to a decreased production of ATP and therefore decrease in contractility. And finally, the endothelial dysfunction, primarily caused by oxidative stress, is one of the factors causing increased myocardial cell death and fibrosis, all of which lead to cardiac failure. Indeed, many studies have shown that insulin resistance is related to the severity of heart failure, is inversely proportional to peak VO2, and is directly proportional to age, triglyceride levels, and levels of noradrenaline and patients with insulin resistance have an increased mortality. Indeed, this is one of many, many studies which has shown that insulin resistance is an independent risk factor for all-cause mortality in patients with heart failure. The other catabolic issue in heart failure is the one of lipolysis, and it is important to note that this occurs through three different pathways, not only through the catecholamines and inflammation, but also the natriuretic peptides themselves through activation of CGMP cause rupture, if you will, of fats into free fatty acids. And this not only contributes to lipolysis, but also is another potentiator of insulin resistance, as I showed you earlier. And in fact, it has been shown that patients with a elevated adiponectin level and patients that have low BMIs due to lipolysis are the patients that had the poorer prognosis in the setting of chronic heart failure. And even if you look at the weight alone, patients whose weight loss is greater than 6% in the setting of chronic heart failure have a greater mortality, a lower survival than those who do not develop pre or actual overt cachexia. We talked about the obesity paradox, and I think that there is an important point to be made here, and that is that the link between adipose tissue and the heart starts with embryogenesis. In fact, once mesenchymal cells are produced, those cells result in the production of blood vessels, adipocytes, and also skeletal muscles and cardiomyocytes. So heart, blood vessel, and adipose tissue have the same embryonic origin, which may explain the interactions between these structures. And someone has proposed that we even identify this problem as adiposopathy, distinguishing what is healthy fat from sick fat. And sick fat occurs as a result of sedentary lifestyle and poor or the intake of the wrong calories, which leads to abnormal adipocytes, which develop a abnormal hypertrophy, and they develop a relative diminution of capillaries, leading to large adipocytes which are poorly supplied by blood. And these abnormal adipocytes are those that produce the inflammatory cytokines that lead to the damage of all the organs that you see there, including increased lipotoxicity to the heart and the kidneys, as mentioned earlier. Another metabolic factor that is very important in heart failure is the iron deficiency, independent of blood loss. And as you know, the FAIR-HF trial has demonstrated that the administration of iron improves functional capacity and quality of life. And importantly, it does so regardless of whether there is or there is not anemia. So the metabolic deficiency of iron is an independent factor which contributes to the progression and worsening of heart failure, whether it is associated with anemia or not. The other important metabolic factor is hyperuricemia. And it's not uric acid per se, which is toxic. What it is toxic is the fact that insulin resistance, tissue catabolism, hypoxia, and also cell death by either necrosis or apoptosis increases purine metabolism, leading to an enhanced xanthine oxidase activity, which in turn produces more cell death, hypoxia, reactive oxygen species, and the increased production of cytokines such as TNF alpha. And this is perhaps why uric acid has been found to be related to survival in patients with heart failure. However, when you use allopurinol, what it is interesting is that this drug has a beneficial effect only in patients that have elevated uric acid, but not in patients with normal uric acid levels. Again, don't get scared by this metabolic graph. This is simply to point out that unfortunately, despite all the metabolic abnormalities that I have shown you, none of the medications specifically targeted to address these metabolic abnormalities have come to fruition, with the exception perhaps of ACE inhibitors, beta blockers, and ranolazine, because of its ability to go from a free fatty acid metabolism to a higher glucose oxidation in the heart. In terms of medication specifically for patients with diabetes, the glitazones are a typical dilemma in heart failure because on one hand, they have been shown to increase fluid overload. On the other hand, they appear to decrease vascular insulin resistance and improve neurohormonal function, improve endothelial function, and also improve glucose uptake in the myocardium. So you have to weigh the risk of fluid overload versus their beneficial metabolic effects. A talk on the endocrinology of heart failure cannot fail to mention the parathyroid hormone, because this hormone actually has the ability to directly stimulate the zona glomerulosa cells to produce more aldosterone, and vice versa, aldosterone, by causing elimination of cations through the kidney, causes secondary hyperparathyroidism, with all the negative consequences of it that we see, for example, in patients with end-stage kidney disease who develop pathologic calcifications in multiple organs, but especially in the blood vessels and even in the myocardium. So that is why, one of the many reasons why mineralocorticoid antagonists have been found so effective regardless of the severity of heart failure with reduced ejection fraction, although they did not achieve this goal in patients with preserved ejection fraction, as we have seen in the TopCat trial. However, there are some metabolic effects of MRAs that need to be mentioned in the setting of the endocrinology of heart failure. One is that when the addition of eplerenone to enalapril was evaluated versus either eplerenone or enalapril alone, all three regimens decreased blood pressure exactly to the same level. However, there was a greater change in LV mass in patients given eplerenone and enalapril, despite similar reductions in blood pressure. A possible explanation is that patients with procollagen 3 elevation at baseline had a greater decrease of such procollagen when treated with spironolactone as opposed to either enalapril or beta blockers alone. Indeed, there is a relationship between the transcardiac extraction of aldosterone and LV remodeling in patients with myocardial infarction. There is a decrease in QTc dispersion and an increase in heart rate variability, which explains the reduction in sudden cardiac death. And there is a definite link also between aldosterone and obstructive sleep apnea that has been repeatedly demonstrated. And furthermore, it appears that the use of mineralocorticoid antagonist slows down the progression of kidney disease and reduces proteinuria. Not only that, but in several studies in patients with heart failure, the treatment with spironolactone has been shown to specifically decrease the incidence of fractures, probably because of its beneficial effects on reducing the risk of secondary hyperparathyroidism. I'm not going to delve into vitamin D deficiency, simply to remind you that what we have found in hypertension is that vitamin D replenishment is more effective in patients that have established hypertension than in patients who do not have hypertension, and that there appear to be a relationship between all-cause mortality and vitamin D level. I won't also dwell on thyroid hormone. Simply, I want to point out that what we know is that the only patients that do not have negative cardiac effects are those that have normal thyroid hormone levels. It is sufficient to have either mild hypothyroidism or mild hyperthyroidism for this to increase the potential for worsening heart failure. Also remember that what we do to the patients, including treatment with amiodarone, can cause various disturbances in the thyroid function that can be of two types, with different therapies and different prognosis. Finally, there is endocrinology also in peripartum cardiomyopathy. Several investigators from South Africa have demonstrated that in women that have peripartum cardiomyopathy, lack of STAT3, you see there what it means, leads to decreased superoxide dismutase, which causes eventually the production of a smaller prolactin molecule of 16 Daltons, which has multiple negative cardiac effects, including endothelial cell apoptosis and vasoconstriction, hence the potential use of bromocriptine in patients with peripartum cardiomyopathy, although this has not been conclusively proven. So I hope I've shown you that the complex interactions between metabolic, immunological, and neuroendocrine signal remains incompletely understood. Abnormal metabolism is an intrinsic aspect of heart failure pathophysiology, and the concept of myocardial failure in heart failure should not be limited to impaired myocardial energy utilization, because systemic energy utilization is also impacted. The heart failure metabolic phenotype is characterized by insulin resistance, a global anabolic blunting, and catabolic overactivity. There are endocrine abnormalities specifically participating in the pathophysiology of peripartum cardiomyopathy, and there are endocrine abnormalities that are iatrogenic, such as the thyroid effects of amiodarone, and targeted metabolic treatment may emerge in the future, but so far we have not found significance in any of the approaches that have been attempted. Thank you very much.